Hello, I would like to thank Dental XP for the invitation for this particular lecture here. I would like to talk to you today about my considerations for the aesthetic zone when we're talking about establishing a workflow from extraction all the way to prosthetic restoration. My name is Thanos Dounis. I am a periodontist here in Fredericksburg. I practice with my wife. Our practice name is Synergy Periodontics and Implants. I am originally from Greece. That's where I did my dental school training as well as my prosthodontics training from 2006 to 2009 for my pros. I was fortunate enough immediately after that to be accepted in the University of Alabama at Birmingham for my periodontics residency. And for a couple of years after that, I taught in the University of Louisville as an assistant professor. And now we have our own private practice. We're fortunate to be here. And I would like to share with you my clinical experiences through my training as well as my start here in Virginia. So let's talk a little bit about our topics for today. I would like to start by the management of extraction sockets. Most of my master's thesis and my research was focused on that particular matter. I have a lot of interest in that particular zone, especially in the aesthetic zone, where we know that there are significant challenges as far as the bone remodeling goes and the changes in the soft and hard tissue. Timing of implant placement, whether or not the case would be suitable for an immediate implant or an early implant or a delayed implant. Some other considerations that have to do with the aesthetic zone. As I mentioned, there are different tissues there do pose a lot of challenges for the clinician. The role that provisional restorations can play, and in fact, even the term provisional restorations now can be replaced by the term of really a guided soft tissue regeneration device. That's how I think we should view the provisional restorations. And again, some other considerations as far as materials go, abutments go for designing final restorations. I think that my ambition today will be to give you a very good workflow and significant pointers about all these topics. I would like to start by establishing some common terminology. And this is an older paper. I like to follow this terminology. A lot of the ITI guidelines have been based on this particular classification. We know that immediate implant placement is classified as type 1, and what's going on in a socket that we have immediately extracted the tooth. There's really not a lot of events that take place immediately after extraction other than very significant blood clot filling that socket, and we need to take advantage of that in the immediate implant placement. That's type 1. Type 2 refers to an early placement where we only have soft tissue healing with some maturation of the soft tissue. That typically is anywhere from 4 to 8 weeks. For example, Dr. Boozer is a big proponent of placing implants at that time frame because it allows any infection that's been in the socket to resolve, as well as have significant soft tissue thickness and maturation to allow for a implant placement as well as bone grafting or guided bone regeneration, if you will, at the same time. Type 3 is more like what I call early delayed implant placement, anywhere from 12 to 16 weeks. At that time frame, we have a significant amount of bone healing, but definitely final maturation of the soft tissue. And of course, type 4, with late placement at that time point, if we haven't intervened before that, we have significant resorption of the bone and a lot of change in the bone architecture. Many of these cases are quite challenging. So with that, let's proceed to another important terminology as far as pre-extraction sockets go. Now, Tarnow and his co-workers from Smith, Elian, and Cho had a very good and very insightful classification. So, for example, here we see 3 types of sockets: type 1, type 2, and type 3. Type 1, you got both the soft tissue and the bone, and the buccal bone, facial buccal plate, if you will, and they're intact. So we got significant amounts of tissues there, okay? These sockets can be considered for type 1 implant placement, for an immediate implant placement, in other words. In type 2 sockets, in type 2 pre-extraction sockets, or in type 2 situations, if you will, just to be more proper, we have some dehiscence of the buccal plate, but the soft tissue is there. And a lot of people tend to make mistakes in these particular cases because they feel that all the tissues are there, while the bone is what's missing. In a type 3 situation, and these are the most challenging cases, we have both lack of soft tissue as well as hard tissue. So this is a classification. Why did I mention that this classification is rather insightful? Well, first, because it shows the pre-extraction condition of a tooth. It's always easier for a surgeon to be able to develop a workflow after we have the defect, after the extraction of the tooth, after the socket is present. At that time point, we can check for fenestrations, we can check for dehiscences in the buccal plate, we can check the soft tissue architecture, we can see if there is any changes that need to be made. But in this particular case, this is the pre-extraction condition of the tooth. And it's good to be able to base any kind of workflow that we're developing in the aesthetic zone in the pre-extraction condition of the tooth. So we're able to tell to our patient, hey, you know what? That tooth looks like it's going to need this and this and this step. And that's how much it's going to cost you. That's how much time it's going to take you. So this is a very important piece of information that we need to capture here. So that's the first reason why this classification is insightful. The other reason is the fact that these are slices. And if you look at them very closely, they will resemble quite a bit slices from a cone beam CT, from a Dell's scan. And this is also very important because although that paper was written back in 2007, even now that most of us have cone beams in our practices and we use them at a great extent, especially those of us who do implants, and I think we should, absolutely, this becomes even more contemporary, even more important. So let's talk a little bit about type 1, about immediate implant placement. And I'll talk to you about my considerations, which I will break down in surgical considerations and restorative considerations. So for type 1 placement, what I would like to see is that the buccal wall is intact. So I avoid sockets that have fenestrations and dehiscences. That doesn't mean that all the evidence agree with me or with my practices. I just feel that I'm safer in my practice to perform this kind of procedure when my buccal wall is intact. Another thing that I'm careful about is I want to make sure that I have thicker biotype, and if not, I would like to change that while I'm placing the implant, and I will talk about how we can do this down the way. And also, if my soft tissue architecture, the existing soft tissue architecture, is satisfactory. In other words, are the papilla where they need to be? Is the gingival margin or the mucosal margin of the future implant where it needs to be? Do these things need to be changed? Do I have enough soft tissue so when the light hits that gingival or mucosal aspect of my restoration, my cervical aspect of my restoration, will that look appropriate and it will match the frame of the adjacent teeth, or will there be an aesthetic challenge in that area? Is there an infection present? There is different data that are published, and now we know that if infections are present and if the sockets are cleaned meticulously with copious irrigation, that doesn't seem to be a problem. Although, if you have a huge fistula and a huge sinus tract, which means that your buccal plate is compromised, that changes the situation. So it is a consideration. Do I have enough bone to anchor an implant at a prosthetically viable and proper position? Not in any position. Anybody can anchor an implant in most of the bone areas we have right now. But we need to make sure that this implant is placed in a position that's prosthetically viable, that can be restored and be aesthetically and functionally pleasing, and also be hygienic eventually for our patient. And I'm talking about the ability to maintain. Do I need to have a facial gap in front of my implant? So in other words, I don't suffocate the socket. Yes, there needs to be a certain degree of distance between the implant body and that thin facial plate. Why? Because that space needs to fill in with a blood clot, and depends on how big or large that space is to allow for that blood clot to be effective in reconstructing the socket or in the socket remodeling, we might or might not use a filler, a bone graft. What kind of bone graft would that be? Would it be a xenograft, or would it be FTBA or a DFTBA bone graft? The tissue biotype that I mentioned before. So these are part of my surgical considerations, and I think that with the cases that we're going to see today, I'm going to be able to show you what are some of the things that I'm looking at. As far as restorative considerations go, say you plan an immediate procedure, you plan an immediate implant in the aesthetic zone. What are the benefits of that procedure? Wouldn't you like to have that immediate implant restored immediately with a provisional prosthesis? Or in other words, with a tissue guiding device, which is a good and nicely made provisional prosthesis. And you won't hear me using the term temporary. I will not be using that term because that's not what we're making for our patients. We want to make sure that there's no occlusal contact in that provisional, especially if we're looking into an immediately non-functional loading scenario. And how is that provisional shaped? That provisional needs to be able to support the existing architecture if the architecture is satisfactory, or be able to allow us to modify the existing architecture to something that's more aesthetically pleasing eventually. So these are some of the restorative considerations that I'm looking at. And then again, what type of material do we need for the provisional restorations? So another thing that we know of, and it's important, this chart comes from a paper by Mariano Sanz from Spain and some great European periodontists, and it shows that in the vast majority of sockets on anterior teeth, the thickness of that buccal plate, the thickness of the buccal wall, is about 0.5 millimeter. In other words, we cannot expect to have 2 millimeters of bone already there when we're placing an immediate implant. That is a study that's compatible with other results. There's been radiographic studies, Januario studies from Brazil, I believe, that shows pretty much the same outcomes. We know also what happens in molars, SROP studies, where we have this huge volumetric resorption of that takes place immediately after the extraction of these teeth. So we know that first we start from a very deficient situation, like Mariano Sanz says, and we also expect to have significant volumetric resorption, mainly in a horizontal level, more than a vertical level, after extraction of teeth. So these are important considerations. We also know now that we don't exactly have a magic bullet to prevent this remodeling from happening. An immediate implant has been shown not to be able by itself to reduce that volumetric or that vertical resorption of the buccal plate. For example, in this case, a couple of things that I would like to notice. This typical patient, younger guy, deep overbite, significant class 2 malocclusion, was only interested in that particular site there. You see that's a number 7, okay? What are some of the things that we see? We have a very good tissue architecture, the papilla are where they need to be, significantly thick biotype, and the tooth is not restorable at this point. Could somebody have performed orthodontic extrusion of the tooth and so on? Certainly, but in this particular case, I do expect to have a good possibility to place an immediate implant. And that's what we did. After extraction of the tooth, there, as you see, I was able to see in the socket, are there fenestrations? Is there any dehiscence of the buccal plate? What is the thickness of the facial tissues, including soft tissue and hard tissue? And also, can I place an implant without, by allowing to have enough space from that implant body to the facial plate? And the answer is yes to all of those. There's no dehiscence, there's no fenestration, soft tissue and hard tissue thickness on the buccal dimension are very satisfactory, and we can go ahead and place an implant and anchor an implant. 3D placement of implant, as you see, that implant comes out between the cingulum and the incisal edge of the adjacent teeth. Why is that important? It is important because it gives the restorative dentist the ability to have a screw retain restoration. Either that's a provisional or a final screw retain restoration. And that's also very, very important. In many cases, in all of the cases, if I should say, the provisional restorations are preferably, in my practice, screw retained, because I view them as tissue shaping, or more like tissue guiding devices that I would like to be able to use to change or support the existing architecture before we proceed to the final restoration. So it is an integral part of being predictable towards our final outcome. So this is the placement. As far as the depth goes, how deep do I want my implant platform to be? And it really depends on what kind of implant you're using. Say, for argument's sake, that most of us use bone level type of implants in the aesthetic zone. Not many place tissue level implants in the aesthetic zone nowadays. So I would like my platform, and of course, I would like my platform of that implant to be about 3 to 4 millimeters below the free gingival margin of the adjacent teeth. Why is that important? It is important because that will allow my restorative dentist to have a proper emergence profile for that restoration. So moving on, and we will have the chance to discuss this further. This is an in-office provisional restoration with composite. Nothing fancy. Implant was placed. You see the implant comes out in the cingulum area of the tooth, not very palatal. And this is how the patient lives the practice that day. We check for occlusion. In this particular case, things were a little bit more challenging because of the deep bite. And we were able to proceed. This is how the implant integrated, and this is the situation with the soft tissues. I do not like to see this nice clean epithelium that lines that implant or transmucosal area. Every time that I remove and replace something on that implant, I would like that something to be completely clean, so nicely polished. If I can use some chlorhexidine gel, which I know in the US I'm having a very hard time finding, I will do that, or just regular chlorhexidine. And sometimes I even like to refresh that inside lining of the transmucosal area. So I do remove some of that epithelium, the inside epithelium, before I replace provisional final restoration. And this is the radiograph with a provisional prosthesis on. You can see the cone beam, and you can see the amount of buccal plate thickness that's present in this particular case. One could argue that maybe the implant is placed somewhat too palatal, although in this particular case, as you saw from the placement, it was, I thought I was, and I still am, in that green zone for proper prosthetics. And this is the two-dimensional X-ray, the periapical radiograph, that shows you exactly where we are in relation with the adjacent teeth. This particular implant is a non-kilos implant. I believe it's a 3.5. In fact, it's a 4.5. In any case, I would also like to mention that throughout this presentation, you will see different implant systems. I will probably refer to them by their name and the different components. I want to make sure that you are aware that I haven't been receiving any honoraria from any implant companies or any other products, and I don't have any stock options. My family doesn't own any stock options in any of these corporations. This is a different patient. That lady was initially treatment plan for a free gingival graft on the lower anterior teeth. In this particular case, there was a significant recession on this teeth. Throughout this process of us seeing her and coming in for her supportive care before her gingival graft, she broke her two front teeth. Significant class 2 again, and a lot of protrusion of numbers 8 and 9. This is the radiographic situation of the teeth before that accident that she had with one of her grandkids takes place. And these teeth were basically fractured with horizontal fractures. And you can see that the amount of overjet that she had, and the protrusion of this teeth really doesn't help our patients in situations of accidents, since these are the first two teeth that were basically are going to be breaking or getting into any other injury situations. So thankfully, the facial plates were intact, and we also know because of the position of the teeth that there's going to be significant amount of apical bone and palatal bone in this particular scenario, and two implants are being placed in an immediate fashion in this situation. And you can also see the amount of distance that is present between the buccal plate and the implant surface. That is important again. That space is very important. That space is important because that's where the blood clot goes and fills these areas. And if that distance is somewhat large, as if it is here, that means that our implants are usually not placed buccal, in a buccal situation, which would lead to recession, as we know, and this is probably the most common complication of immediate implant placement. And we also know that we probably chose a correct size of implants that will allow proper emergence profile as well as not suffocating of that socket. Allow that space to breathe, allow that blood clot to start restructuring that socket. And in this particular area, of course, we are going to use some filler material, and we did use FTBA in this particular case. This is the tissue thickness about 3 to 4 days, in fact about a week after the extractions, and you can see the abundance of soft tissue that we have. Please note that these healing abutments are 5 millimeters high, so our implants are placed about 3 to 4 millimeters below the free gingival margins of the adjacent teeth. Of course, we made the impressions at the day of surgery. This is the radiographic image of these implants here. And these are the provisionals that are made. These provisionals are delivered, again, as I said, 3 to 4 days to a week, maximum a week, if we have good primary stability of those implants. Ideally, I would like to deliver them within 24 to 48 hours. Ideally, I would like to deliver them immediately the same day. But because I want those provisionals to be manufactured properly, to be polished, to look good, and allow my tissues to integrate properly around them. Sometimes the lab does take time, and I am not concerned if I'm going to deliver a proper provisional or a proper tissue guiding device 3-4 days later after the implant placement. And this is the day of delivery. This is at 4 weeks. You can see the nice amount of tissue maturation that we have around this teeth. And this is the initial situation and the situation after that. And this is our patient. All we have to do now is, once those implants integrate in about 3-4 months, we are going to be able to duplicate the emergence profile of those provisional restorations, and I'll show you how, to the finals. Other considerations for this particular case, we completely changed the position of these teeth. So I suggest that when we do this, when immediate implants are placed and the crowns do not correspond to the crown of the tooth that failed or had to be extracted, then I suggest this implant placement takes place with a surgical guide. It is very important because you want exactly that implant to be corresponding to the future crown, which has nothing to do with what you had in the prior situation. And that's what happened in this particular case. So what happens when we take a tooth out? Histologically. At 6 weeks, what you're going to see, and I'm not sure if you can see those purple islands in this somewhat whitish matrix. What these purple islands show us is basically new bone forming. And this is a core that was taken from an extraction socket that was allowed to heal for about 6 weeks. And this is from my master's thesis in the University of Alabama at Birmingham, which we later published. And what we found was that if at the same time with the extraction we can place bone replacement graft and either PDGF, human recombinant PDGF, or platelet-rich plasma and mix it with our bone graft, then we are able to somewhat speed up that growth of native bone, as well as the integration of and remodeling of bone graft particles within the socket. With the green here on your right side, you see the amount of new bone that's present. With blue, you see the amount basically of, and I don't want to say soft tissue, but amorphous organic matrix. And with yellow, you basically see air that's present in all sockets when we take a core of histology, especially that early. So is that important? Yes, because if the original study had, say, 4 groups, and I'm going to go back a little bit. The first group, you just placed a collagen plaque. The second group, you were placing FTBA, beta TCP, and a collagen plaque. In the third group, you were placing FTBA, beta TCP, and PRP. And in the fourth group, we would place freeze-dried bone allograft, beta tricalcium phosphate, and human recombinant PDGF. Those 2 last things together are in the market under the name of GEM21. And additionally, collagen plaque. And we let them heal for about 8 weeks, 2 months. What we will find is something that looks like that in the histology. And the colors on your right side correspond, and they're exactly the same. So green is new vital bone, blue is amorphous organic matrix. With red, you see residual particles that remain in the histology, and with yellow, you basically see air. So what we found is that once we were incorporating those growth factors, the amalgamation, if you will, between the new bone that was forming in the socket with the residual particles was faster when the growth factors were present. Okay, so that's an important histologic finding. And you can find that particular paper in the International Journal of Oromaxillofacial Implants in 2014. At the same time, every time you incorporate bone graft, you should expect less vital or new bone in your sockets. That makes sense because new bone has more space to form. At the same time, you get no primary stability if you have no bone graft at 8 weeks. So bone graft is important, and especially if you can combine that with growth factors, that allows you to speed up that process and get also new bone more than you would without them, without the growth factors, and primary stability, which is basically higher primary stability, which is basically the advantage of incorporating bone graft in the sockets. Now, of course, considerations have to be taken place, and not every socket needs a growth factor. But if you got a patient who has any kind of osseous metabolic conditions that pose a challenge to normal healing of sockets, or if you're in a situation where we would like to accelerate that healing process, growth factors might not be a bad idea. Additionally, if we were to compare clinically the assessment of bone quality with 3 different operators that are placing implants on sockets that did have growth factors with the bone allograft and sockets that did not have growth factors with the bone allograft, interestingly, what we find is that a significant amount of D2 bone was present in the sockets that we combined with growth factors versus not present in the sockets that were not combined with growth factors. So the bone quality was better at 6 to 8 weeks. That means that you could go back potentially for an early implant placement and have no problems whatsoever with your primary stability. And this is what you see here with blue color is D2, D3, D4, and some missing data there. So in the 3 and 4 group that growth factors were present, the quality of bone is significantly better. Look at the amount of blue you have on the group 3 and group 4 comparing to the group 2 and group 1. Group 1 again is the one that's full of vital green bone that you saw before. So that is a significant advantage because This is one of the very few studies that I'm aware of that follow the sockets that early, that the histology is taken at 8 weeks. That's quite early. In fact, in that study, and these are unpublished results, none of the implants failed throughout the time frame of follow-up of that study. So that was at least a year. That means there were no early failures of implants. So all implants were able to be placed and anchored properly and integrate without any issues and do well for that first year after the extraction of teeth at 8 weeks. All right, so let's turn the page again. Let's go to clinical stuff, and I would like to talk to you a little bit about that article that I wrote with Dr. Stavros Pelekanos. He's a prosthetist from Athens, Greece. He's practicing there, and some of you may know him. He's well renowned in the lecturing circle. So in this particular paper that was published in the Clinical Advances in Periodontics about 4 years ago, we presented this particular case. We have a failing number 8. You can see the sinus tract. We know what we're going to find in this particular scenario. Okay, horizontal fracture. I would call this a type 2 socket with Tarnos classification. Is that fair? Yes, because I think there's enough soft tissue, but at the same time we know that there's going to be dehiscence, if not a fenestration of the buccal plate, or both. There's going to be some loss of buccal plate in any case. So once the tooth is out, this is the amount of destruction that you see. In this particular situation, is this a good immediate implant situation? For me, it's not. I would like that area to be cleaned. I would like to reconstruct that area. And although I could potentially anchor that implant, I think I am too close to the nasal cavity. So I would like that bone graft or that guided bone regeneration to take its full effect first, let it heal for about 5 to 6 months, and then come later and place an implant at a prosthetically proper position. So what you see on the right image is about 6 months later after what you see on the first image. This area was reconstructed. It can be reconstructed with a resolvable membrane. The defect is containable. Okay, I don't think there's any need here for a titanium reinforced membrane. But even if the defect was not containable, then we could have used the titanium reinforced membrane with absolutely no problem. So when the implant is placed, once the implant is placed, a surgical impression can be made, and a temporary or a provisional restoration can be delivered. Not only that, but the provisional restoration will provide you an area where tissue can grow around it. But what happens if we don't have enough tissue? That's when we need to add tissue. And in this particular case, connective tissue graft was done at the same time of delivery of that provisional restoration. One of the things that I would like to point out is how narrow, close to zero, that emergence profile of the provisional restoration is. So if we were to go back to this great paper by Lee and co-workers, he developed this concept, and this is more like a concept paper. Okay, it's a technique paper. He developed the concept of critical versus subcritical contour. And the critical crown contour is the kind of contour that if you change it, you'll see changes in the shape of the clinical crown. You'll see changes in what happens above the gum line, in what's visible for the patient. If you change the subcritical contour, that means that you incorporate changes that are taking place below the gum line. You incorporate changes that are taking place and can guide the tissue differently. So you can potentially change or manipulate the tissue by changing the subcritical contour and retaining the critical contour the same, so the shape of the crown is the same, but at the same time you're able to manipulate the tissues below what's visible, below the visible line, right, below the CJ, if you will. So if we, in our case, how did we use that concept? If we allow that tissue to heal, we're able, by incorporating small changes in that provisional, screw-retained provisional that you see in this particular case, and that's important to have it screw-retained because you can remove it. So going back, we can let it potentially heal there as it is by allowing it and giving it space. We can make these changes happen in the provisional, and at this time point, what we see, we can start like this, with somewhat of a minimal emergence profile and slowly start building. In that case, what you see here with the black marker line is where the gingival margin is, where the mucosal margin is of that implant. Okay, and we found that at the end stages of this treatment, we were basically pushing the buccal tissue, the facial tissue, away, and we were basically not allowing it to reach its maximum potential. So we wanted to make sure that we allow that tissue to reach its maximum potential. And the best way to do that is by reshape or remove part of that provisional. And that's exactly what happened. So what Stavros did here, he started like this, what you see in this particular area, and by basically changing the subcritical contour of the provisional, the crown of the shape never changed. The shape of the crown never changed. We were able to reach that outcome. So how do we do this? Same case here. That's the same case here. What you see is the final end point of the provisional. What you have here is, I'm really sorry, I'm going to have to go back on that. What you have here is the provisional comes out, it's screw retained, it's connected to an implant analog. Silicone putty is placed around that provisional and the implant analog. This is a very common procedure on how to do this. The silicone putty reaches all the way up to the maximum circumference of the tooth, and it's cut there, so we don't need that additional excess. Okay. And again, this is a video that's incorporated in the journal, the Clinical Advances in Periodontics. This is an interactive journal by the American Academy of Periodontology. So, the provisional is removed, an impression coping is placed, and now you can see the discrepancy between your crown, between our crown, and the prefabricated impression coping. So we need to fill that space. You can use pattern resin for that. You can use flowable resin, composite. You can use anything you like. Something that's, of course, stable in terms of dimensional stability after polymerization. So this is a customized impression coping for that particular tooth that we can use to make that impression. And that allows you, from a situation that we started like this, very deficient situation, to go all the way to your right and what you see to your right, the right image. And that's a very satisfactory situation. That is a great reconstruction for that particular patient. Could that result have been achieved with an immediate implant in this case? No, because our challenges were a class 2 socket, significant loss of the buccal plate, significant destruction of the buccal plate, infection present because you had the sinus tract, and the soft tissue, believe it or not, was not enough. So that soft tissue needed to be enhanced by a connective tissue graft. So two keys to solve this case. One was provisional, that allows you to manage that soft tissue, and the other one was connective tissue, subepithelial connective tissue graft, that allows you to add to the existing tissue so we can manage it. And with these two things at the same time, and a little bit of patience, because these cases take time, and you might have to see that patient at least once a month to make those changes for about 2 to 3 months. Then we can reach that outcome. It's hard to say how much time it takes, and every case is different, every person is different. That particular lady was fairly young, and we were able to do this. In other words, common sense considerations. If the implant is still with that green zone, very clinically acceptable, but it's somewhat buccal, then we want to make sure that we under-contour the subcritical contour that Ernesto Lee says. If the implant is placed exactly where it needs to be, all you have to do, and you have the soft tissue thickness and you don't have to change anything, all you have to do is support the existing architecture. You don't need to change anything. Just try to emerge the same way that natural tooth was. If the implant is still within that green zone, and all these three situations are clinically acceptable, right? So if that implant is still within that green zone, but we need some support of that buccal tissue, then all we have to do is somewhat over-contour that buccal tissue. All right, so here we are, before and after, immediately after the provisional is placed, at the end of the restoration, and that's all this case. Before we move on, let me introduce to you this patient. This patient was um, a friend who me and I were sharing the same working environment, and he had an accident previously with number 9. He fell off a ladder, hit his face. That was a few years back. So that tooth right now has a significant resorption process that you can see clinically. Okay, and this is more of an internal resorption that has progressed significantly, and you'll see that later on the scan and on the X-rays. Other things that we see here, the architecture is very satisfactory, right? There's no loss of papilla, there's no clinical recession. There is some lingual version of that number 9, which tells you that the root is probably where? Buccal, facial, right? And if the root is facial, then what do you have there? We got fenestration, most likely, or very likely, right? So this is a tooth that we know might or might not be indicated for an immediate implant. Unlike the first case of immediate that we saw, where that lady had her 2 teeth protruding, this is exactly the opposite situation. And when you have that lingual version of that tooth, that's probably a very challenging situation to solve in terms of placing an immediate implant. So this is a side view, and you can now appreciate the amount of lingual version of that tooth, of the crown of that tooth. Excuse me. And this is the cone beam. What do we see in the cone beam? Well, first, we see how much significant that resorption is. Number 2, we see that most likely there's a fenestration at the most apical portion of that root. So, since we're not keeping the position of the tooth, and in this particular case, I'm working with a prosthodontics resident from the University of Louisville. His name is Dr. Adrian Polini, and he's the restorative doctor of this case. I am the surgeon of this case. What Adrian did, he did a complete new wax-up of that tooth in a prosthetically proper position, where that tooth needs to be. I was able to take the tooth out en toto, in one piece, and you can now appreciate the amount of significant damage that the resorption has caused. And I love this picture. Take a look at this picture. This picture shows 2 things. Shows what Sans was talking about, how thin that buccal plate is. And remember, this particular patient, when you see him, he has very thick biotype. I mean, his gum biotype, his gingival biotype is very, very thick. So you expect to have significant thickness of the facial plate. Well, that's not the case. Nobody has thick facial plate. I promise you that. At least I haven't seen one so far. The other thing that you see is how important it is to take that tooth out very gently. And I tell my patients, I use periotomes. Of course, I use surgical loops and so on, and I take my time. I take as much time as I need, because this is a very important part of the wound healing process, to be able to keep that even compromised facial plate. Are we surprised by seeing a fenestration down there at the most apical portion? Certainly not. We knew that from the cone beam. Okay. One of my colleagues asked me the last time I lectured by using this particular case, why didn't you just take that buccal plate out? It's going to atrophy anyway. It's going to resorb. It's going to go away. Why didn't you just take the tooth out? It would take you less time, and you wouldn't have to worry about any of that, retaining any of that. Truth of the matter is, if we were to take the tooth out by basically removing the facial plate with it in this particular situation, and I know most of you right now are already feeling nauseous just by hearing about it, I'm one of you, the wound dynamic completely changes. From a containable defect, you go to a non-containable defect. From the ability to use a resorbable membrane, now we have to use a titanium reinforced membrane, increasing our potential complications. So, different ballgame if that thin facial plate goes away. Do I know that this plate will eventually go away? Certainly. But is it serving me really well at this point, and will it allow a better architecture of that socket once we reconstruct it? Yes. Yes, and I will show you how to reconstruct the socket. So while I was in Louisville, Dr. Greenwell there has a significant research data that shows us that in the aesthetic zone, from canine to canine, and most of this research is published with different residents. I think that's going to be a good literature review. Whoever wants to pursue that shows that just by placing human allograft inside the socket, we still get significant amount of absorption of that socket volumetrically. I have found myself in a situation where I used to take the tooth out, place human allograft in a socket, put a collar plug, and then I would go in 3-4 months down the way, and the dimensions of the bone were not enough or were not satisfactory, not to anchor the implant. That was not a problem, but mainly to have a good architecture around my implant, to have enough thickness of buccal plate around my implant. And that started to concern me. So I started doing this, and it's a little bit more invasive, but in a situation like that where I know there's a fenestration, I started taking the tooth out, a little bit more aggressive incision design that you see here. I was placing human allograft in the socket, and I would layer the outside of the socket with bovine xenograft. And there's a number of studies. I think the most representative one is by a Greek resident in Louisville. His name is Pouias and Greenwell, that shows that by combining these two biomaterials in the fashion that you see here, reduces significantly the amount of volumetric resorption that's going to take place in that socket. So I also layered a BioGuide membrane outside my bovine bone graft. Was that necessary? Yes and no. Yes and no. I feel better by doing that because I have found that there's a recent publication by a German scientist, and it was a coincidental finding that shows that when bovine xenograft comes into contact with connective tissue, there's a potential of some of the undifferentiated mesenchymal cells turning over to osteoclasts and start remodeling or resorbing, start basically eating away those bovine bone xenograft particles. So just by reading that, I started layering a collagen membrane in this particular situation. And this is how everything healed. Okay, nice and fine, but at the same time, what do you see? Take a look closely. What you see here is, although the socket healed, we are significantly deficient in a volumetric situation. Significantly deficient in a volumetric situation. So going back in about 3 to 4 months, and I love the picture on the left. What you see on the most apical portion of the picture on the left, you see that original buccal plate, part of that original buccal plate. And that's what remained. So that was maintained. And that was maintained because we allowed that buccal plate to survive with our careful extraction. At that time point, we were able to place an implant by utilizing Adrian's surgical guide, because he did have a wax up from where the future crown used to be. Once the implant was placed, and this is a bone level Straumann implant, once the implant was placed, and I would like to make a few comments about the implant placement. First is how deep the implant goes. Again, following the same rule that I mentioned before, 3 to 4 millimeters from the free gingival margin of the adjacent teeth. Okay. Mesiodistally, I'm right at the center of these two teeth over there. That's not a problem. What about baccolingually? I want to make sure I'm between the cingulum and the incisal edge of the adjacent sentinel incisor. That allows my prosthodontist, my restorative doctor, to have the option of screw retainer restoration. Okay, so implant goes in, you can see the amount of bone that's around that implant. That's a very nice and safe situation. And once the implant is in, we can make an impression or a surgical indexing of that implant once the implant is in, and kind of keep it on the side. That will allow us to fabricate a provisional that will be ready to go once we uncover that implant, right? And that's what we do. Very simple process here for the surgical indexing. We're in the green zone. We're in good shape baccolingually. But remember what I said? We were deficient baccolingually. So I added more xenograft, added an extra collagen membrane, and I did a subepithelial connective tissue graft. Do I care to get primary closure in this situation? Not really. In fact, I would definitely appreciate to have a little bit more granulation tissue in between. That gives me more tissue. That connective tissue, nothing will happen to it. It will remodel just fine. And this is the before and after of this process. Now we can start talking. Now we can start talking about a restoration in this particular area that will be aesthetically pleasing. Because, especially if we're making a provisional in this particular situation, or if we want the option of placing the definitive abutment immediately on uncovery, we have that option. We have the option of soft tissue thickness that's appropriate enough to be able to deliver that outcome. Nice healing situation here. Okay, so what we got? Remember we had a wax up of the original of the crown where we needed to go. Adrian can work on making a cast by incorporating his surgical impression, his indexing in that new cast, and have the wax up, the implant position by creating a second cast with his index, and a third cast 4 months after healing, which is just being made with just an alginate impression of how things are looking with a nice bulk we created. So you got 3 casts now. One is your wax up, the second one is your implant, the third one is how your soft tissues look. Well, that's great. Why? Because you can scan these casts. Now you have 3 digital casts. And something that you cannot do in an analog way is that put them all together. You can superimpose those 3 casts together. What do you have? You have where the crown is, you have the soft tissue thickness, and you have your implant place, your implant position. And on that software, we can design our definitive abutment, or we can design a provisional that shapes exactly how we want it. And this is a milled PMMA provisional that was used. It can be cemented on a titanium base abutment, and you can see the steps of cementation here. Of course, we need this to be extremely clean. This is going to be in the patient's mouth. This is going to be in the tissue that we created with such patience and such method. So we want to make sure that final step, that tissue guiding device that we're going to be connecting to our implant is perfectly clean, like what you see here. And this is the final provisional. After that, our lab technician or our dentist, the restorative dentist, can take all the time that they want, cut it back, start layering with composite, and do all this beautiful restorative dentistry stuff that we see. And Adrian is very talented. This is the final provisional and the final critical and subcritical contour. Look at where the access hole is. I want this to be there. Myself as a surgeon, if all my aesthetic zone implants are not coming out from where you see it right now, I think I probably should have done something better. And I feel bad if I don't make it every single time, 100% of the times. So, our provisional is ready. We're 4 months out. The implant is integrated. Are we ready for uncovery and basically placing that provisional? Certainly not. Certainly yes, we are. Got plenty of tissue quality. Our uncovery procedure needs to be minimal. We don't need to change anything. We don't need to add any more connective tissue. We got everything we want. And this is a small roll technique. So what I did is I used diamond burr to deepithelialize that tissue and basically create a small trapdoor incision and roll it on the facial, expose that implant, remove the cover screw, and position the provisional in that area. No sutures. Patient is hemostatic the moment the provisional goes in. We don't have to do anything about it. Just let the tissues heal. And this is how the tissues are starting to heal. This is the final stages of tissue maturation with the provisional. And our lab technician can start working on producing the final. But before that, we need to give him some information. The provisional will be removed. This is the transmucosal profile that we have established with all the work that we did. Look at the thickness of the tissue. I love this case because yes, it did take us longer. Yes, we did use different biomaterials, but this is our reward, and this is the time to basically see the outcomes of these procedures. As I showed you again, using silicone putty, we copy that emergence profile like in the video. We place that prefabricated implant impression component on that implant analog, and we're going to use pattern resin to fill the gap to create a customized impression coping that matches the emergence profile of that provisional, of that particular patient, of that particular tooth. Not only bacolingually, but also mesiodistally in all dimensions of that tooth. We need to have that copy emergence profile, like you see in the image here. And with that, Adrian is going to make an impression. And we like when we take different shades, when we have our final color communication, to use workflow with polarizing filters in front of our lens. The best one, I think, at this point, in my opinion, is the Polar Eyes by Bioemulation. And we use it extensively to communicate with the lab, and that's part of the workflow of communicating with the lab, the proper shade for our restoration. And the lab technician of this case, I think it's Mr. Ali Hodges, which I would like also to thank him for the beautiful work that he did here. And this is the final outcome. Is it perfect? No, but it's pretty close. And this is immediately after we placed that crown on. So there's still way to go, and I think it's going to look even better. So, for a closing, I would like to show you two quick cases where myself and my wife, my partner here in the practice, Dr. Lily Pittman, were able to develop a protocol that we are calling the ABC. It is called ABC because we use 3 different sequences of biomaterials. One is autogenous bone graft, B is bovine xenograft, and C is connective tissue. This protocol came as an idea because we wanted to combine everything that we feel is important for our restorations in the aesthetic zone. Additional tissue, additional volume, more space for the tissue, less space for restorative materials, and also use a tissue guiding device or a provisional to reach the final outcome predictably. So this particular friend here is missing congenitally missing number 7. Orthodontics did take place. We could definitely have a little bit more room for implant number 7. With our study, we determined that we could make it by utilizing a narrower diameter implant, a smaller diameter implant. In this particular case, we're using a BioHorizons 3.0 millimeter implant. And you can see that there's significant concavity on the buccal. There is also below that, and that picture doesn't quite show it really well, some exposure of that of the implant surface. and I use scrapings of autogenous bone to layer the area of that exposure. But before we go into that, that case was originally planned for a guided case, and although I did the study myself in the software, what I got as a guide was exactly where I did not want my implant to be. So that implant was placed basically in a freehand manner, not a stress-free day, a quite stressful day, if I should say. This is the 3.0 implant, and you can see that we're right at 1.5 millimeters from each tooth, and that's the minimum amount of space we need to have. And on your left, you see, just for demonstration purposes, the sequence of biomaterials. There's autogenous bone layering that exposed implant. There is bovine xenograft right on top of that. We will place a membrane for the reason that I previously explained, that we need to make sure that there's no direct contact between connective tissue and bovine xenograft. So we will place a collagen membrane. I will add my connective tissue, my subepithelial connective tissue, and because this is an all-inclusive protocol for a non-functional provisional restoration the same day with the implant, we will make a provisional that day. So you can see the three biomaterials here in sequence and the temporary cylinder that was used for the provisional restoration. And this is our patient about 2 to 3 weeks after the whole event. We got very nice tissue integration. The fact that he had thick biotype is definitely very, very, very helpful. And all we have to do, copy the emergence profile. This is before final restoration. This is still his provisional number 7. You can see the amount of thickness that we have achieved. Quite comparable from side to side. And because the implant system does not allow at this diameter for a different type of material of abutment, we're using a UCLA abutment. And to be honest with you, we know from the Jung studies that if we have a certain thickness of soft tissue, we have more than 2 millimeters of soft tissue. It doesn't matter what your abutment is made of. And especially a UCLA that has that nice gold hue will definitely give you a very nice aesthetic outcome, and that's what we chose for that case. The other thing that I want you to notice here is that this is a custom UCLA abutment, and the margin that allows us to position the margin not more than 0.5 millimeter below the free mucosal margin for the restoration. So I can have a cementation process that is more appropriate without running the risk of leaving any cement. So, final restoration, you see it here in this image, very acceptable. And the final outcome, profile shot. And the last case of the day, and I'm going to leave you with that, is another ABC case. This young lady here has 7 and 10 resorbed because of orthodontic extrusion of numbers 6 and 11. In that process, unfortunately, the roots were resorbed, as you can see here in the panoramic x-ray. You can also see the amount of resorption that's present on number 7, that pink hue that it has. There is an amount of altered passive eruption for the trained eye here. That particular altered passive eruption, though, was classified according to Koslet as the type that only involves soft tissue and not hard tissue. And of course, the case was planned digitally. You can see the amount of native bone that's present. If we are to use any of that autogenous bone, it will be very minimal, and that would satisfy the first part of the ABC protocol. Again, the ABC protocol definitely has provisional restorations to be placed at the day of surgery. It's an all-inclusive protocol. And although it is an immediate implantation scenario, as I said, it's mainly a situation where there's no roots, so I don't quite consider that a true immediate implantation scenario. The ridge is already there, and it's somewhat deficient. But it's to a point where an implant can be placed in a prosthetically driven manner, and we just layer our biomaterials, autogenous, bone-vine-bone, membrane, and connective tissue. In this particular case, we're using a permanent prefabricated abutment as a temporary abutment. And after 2 weeks, after things have come down quite a bit, we're starting to see where we are. And this is the final outcome. So it is quite decent. The gingival zeniths were not the same to begin with. We see good tissue integration. I'll let you appreciate also the volume that's present there occlusally. And this is the final radiographic image. Our young patient is quite happy, and I think the ABC was used to her best benefit in this particular case. I'm very much looking forward to following up on these cases with a more extensive research that shows us the dimensional stability with this sequence of biomaterials. Just an important point to make, this is again in situations where the tooth is missing. That second case that I showed, although the tooth was not missing, the roots were pretty much, so it kind of fits in the same category. So just to summarize, I showed you about 5 or 6 cases. Each one was different. First 2 cases were immediate implants that the prerequisites were all there. The second case was a case done with Dr. Stavros Pelekanos, where there was a significant amount of buccal plate loss and had to be reconstructed. And at that time, we used connective tissue graft and a provisional to allow that to happen. Very similar situation in the third case, where I worked with Dr. Edino Pollini. And there we were able to have the provisional ready to go at the time of uncovery without really changing anything of the existing architecture, because it was optimum because of the amount of connective tissue graft that had been done and the amount of reconstructive work. And of course, the 2 last cases, the ABC cases, where the provisional again was placed with the connective tissue graft at the same time. And to summarize, my personal approach is more of a biologic approach. I prefer more space for my tissue, less space for the restorative materials, use of autogenous soft tissue grafts for enhancing peri-implant tissues, and I use my provisionals on implants as tissue guiding devices. I think with following these protocols, I'm able to achieve long-term stability of my peri-implant tissue, something that looks good, it's hygienic, the patient can clean it, and they can maintain their implants, hopefully for the rest of their lives. Maintenance is also a big part of it. So with that, I would like to leave you. Thank you with this, and thank you with this image of beautiful Fredericksburg, Virginia. This is the mighty Rappahannock River. Runs through the downtown of Fredericksburg. If you're ever in the area, feel free to reach out. From Synergy Periodontics and Implants, I would like to thank you so much. Feel free to give me a call or send us an email in case you need anything and we can help you with anything. Again, thank you Dental XP for this great opportunity. I'm looking forward to working with you in the future and be part of this great team of individuals and clinicians. Thank you so much.